It's really quite startling, isn't it? That statistic, over half of older adults might experience delirium after surgery.
It really is. It highlights just how vulnerable our cognition can become, especially, later in life.
Yeah. And then you add that figure about Alzheimer's.
Yeah.
Someone diagnosed basically every minute in the U.S.
It just shows the sheer scale, doesn't it? The scale of these neurocognitive challenges we're really grappling with.
Exactly. And that's what we're getting into today. We're working from a pretty comprehensive chapter all about neurocognitive disorders.
Right.
And our focus is going to be on trying to understand two big ones, delirium and Alzheimer's disease.
And this is such important stuff. Like you said, people listening might have very different levels of knowledge already.
Sure.
So the idea is to pull out the really key insights, make things clearer, but without, drowning you in every single detail.
Right, getting that core understanding. So we want to clearly show the differences between delirium and AD, look at what causes them, the symptoms, and really importantly, what it all means for care and support.
Makes sense.
Okay, so let's unpack this, starting with delirium.
That sounds good. So delirium, at its core, it's a temporary cognitive issue. But the key thing, the absolute key, is that it's always caused by something else.
It doesn't just happen on its own?
Never. It's secondary to some other physiological problem going on in the body.
So medical conditions, obviously, but also things like substance use, or even reactions to medications or toxins.
Precisely, all of those. And what's really significant and kind of hopeful in a way is that full recovery is possible.
If the underlying cause is dealt with quickly.
Yes, if it's identified and treated promptly, the delirium can resolve completely. But, and this is the crucial bit, if it's missed or untreated.
Then you're looking at potentially more serious things down the line.
Unfortunately, yes. It can increase the risk of developing dementia later on, and sadly, it's even linked to increased mortality.
Wow. That really underscores why things like screening in hospitals are so critical, doesn't it?
Yeah.
It must impact recovery times, costs.
Hugely. And it's much more common than people often think, especially as the chapter notes, in older adults after surgery, folks in the ICU, nursing home residents.
Those vulnerable groups.
Exactly. We really need to stress how prevalent it is. And it's not just the confusion itself. It's linked to higher death rates, more falls, declines in function, both physical and cognitive, and it adds a massive burden to healthcare costs.
And, concerningly, it often gets missed or misdiagnosed.
That happens a lot, which is why really understanding the signs and symptoms is just so vital for everyone, not just healthcare professionals.
Okay, so what are those defining features? What should we be looking for?
Well, a big one is a disturbance in attention and awareness. So the person might find it really hard to focus or stay focused or shift their attention.
It might seem sort of out of it or disoriented.
Exactly. Disoriented, maybe withdrawn, sometimes almost unresponsive.
And it affects thinking skills too, right? Cognition.
Yes, definitely. Memory problems are common, especially with recent stuff. They might be confused about who they are, where they are, the time.
Basic orientation.
Right. And language can be affected too. Their speech might ramble or not make sense. They might have trouble understanding you or speaking clearly, or even reading and writing.
And then there are those perceptual things, hallucinations and illusions.
Yeah, those can be really frightening. Illusions are misinterpretations of real things, like mistaking bedsheets for rats or an IV tube for a snake.
Okay, so it's a misinterpretation of something actually there.
Correct. And often, if you calmly explain what the object really is, that can help clarify it for them. Hallucinations, on the other hand, are seeing or maybe feeling things that aren't there at all.
Like seeing insects.
Visual ones are quite common in delirium, yeah. Seeing insects, animals, sometimes people.
And a key feature is how quickly this all comes on.
Very key. It develops rapidly, usually over hours or maybe a few days. And the severity can fluctuate a lot during the day.
Like that sundowning idea, worse in the evening.
That's a classic example of the fluctuation, yes. Symptoms often worsen in the late afternoon or evening. That's quite different from the more steady decline you typically see in something like Alzheimer's.
So that fluctuation is a big clue for delirium.
It really is. And for a diagnosis, you absolutely need evidence that these disturbances are a direct result of that underlying medical condition or substance use or whatever the trigger is.
It's not just cognitive changes, though, is it? There are behavioral symptoms, too.
Oh, definitely. People can become very restless, agitated, even combative sometimes.
Oh, the opposite. Very withdrawn.
Yes, or they might sleep excessively or have their sleep-wake cycle completely flipped. Some become very quiet, slowed down in their movements and speech.
And emotions can be all over the place.
Completely unpredictable. Rapid mood swings, irritable, angry, then maybe suddenly euphoric or anxious or just flat and apathetic. Paranoia can creep in too.
The chapter mentions different types: hyperactive, hypoactive.
Right. Hyperactive is the one we often picture agitated, restless. Hypoactive involves being lethargic, slowed down, and it's actually the type that's most often missed.
Because it's less disruptive, I suppose.
Exactly. And then there's a mixed type where they fluctuate between the two.
Okay. So given this complex picture, how do healthcare teams actually assess for delirium? Screen for it.
Well, assessment really starts with recognizing who's at risk and then ongoing monitoring. There are specific screening tools, but the chapter mentions a handy mnemonic, mind spaces.
Mind spaces. What does that stand for?
It helps remember key risk areas.
Yeah.
M for medications, I for infection or advanced illness, N for number of comorbidities. It covers the main bases.
And those underlying causes.
Yeah.
The list seems huge. Surgery, withdrawal, infections, metabolic issues like dehydration.
It is huge. Nutritional deficiencies, specific drugs, neurological diseases, tumors, even things you might not immediately think of, like being moved to a new room, sensory deprivation, lack of sleep, pain.
Immobilized.
Yes, even immobilization. And terminal illness, of course. It's very broad range.
Which makes diagnosis tricky, I imagine.
It absolutely does. And when assessing, you have to remember how hard it might be to even talk to the person because of those attention and memory problems.
Right.
Even quite significant memory issues might only come out with careful questioning, especially if the delirium is milder.
And those illusions and hallucinations, they must feel very real to the person.
Totally real and often very frightening. As we said, visual hallucinations are common, but tactile ones, feeling things crawling on the skin, for instance, can happen too. Auditory ones are less typical in delirium, more common in other disorders.
Does the person usually know something's wrong?
Often, yes. They might explicitly say their thoughts feel jumbled or mixed up. They might express fear or anxiety about what they're experiencing.
It sounds like a state of extreme vulnerability. What about their physical safety? That must be a major concern.
It's the number one priority. Because they're disoriented, they might try to leave, maybe feeling they desperately need to go home, even if they are home.
Or act on those misinterpretations, like the snake example.
Yes, potentially leading to dangerous actions. The risk of wandering off, pulling out 5E lines or catheters, falling, it's all significantly increased.
So the environment needs to be managed carefully.
Absolutely. Simple, clear environment, clocks, calendars for orientation, good lighting, but avoiding glare, making absolutely sure they have their glasses and hearing aids if they use them.
Familiar cues.
Exactly. Familiar cues help anchor them.
And the disrupted sleep and fluctuating consciousness add to the risk.
Definitely. They might be drowsy and hard to rouse, or suddenly become hypervigilant, scanning the room, easily startled, agitated, especially at night.
And those unpredictable moods and behaviors.
Yes, the labile moods and erratic behavior just compound the safety challenges.
So from a nursing perspective, what are the key interventions? Where do you start?
Safety first, always. Preventing falls, preventing them from harming themselves, addressing those underlying physical imbalances causing the delirium.
And helping with orientation.
Crucial. Consistently introducing yourself, using their name, keeping instructions calm, short, and simple. Face-to-face contact is important. Gently correcting misperceptions, reorienting them frequently to time, place, person.
Using things like family photos.
Great idea. Familiar objects, family pictures can be very grounding, and validating their feelings, even if the perception is wrong, is important. Encouraging family visits or calls helps too. Respectful communication is key.
What about managing sensory input?
Try to maintain normal routines as much as possible. Ensure those sensory aids are used. Keep lighting appropriate, maybe open blinds during the day. Personalize TV or radio if it helps, but avoid overstimulation. Meaningful, simple conversation. Consulting therapy services if needed.
And pain control, mobility.
Absolutely vital. Assess and treat pain effectively. And early mobility is encouraged. Getting them up and moving helps prevent complications and can reduce the need for restraints, which should be avoided whenever possible.
Nutrition and elimination too.
Got to keep an eye on that. Can they feed themselves? Monitor their intake, their weight, regular toileting schedule, managing constipation. It's all part of the picture.
And sleep, that disrupted cycle.
Promoting good sleep hygiene is key. Designated rest periods, reducing noise, maybe relaxation techniques, clustering nursing care to avoid waking them unnecessarily, trying to avoid hypnotic medications if possible.
And if someone becomes combative?
The advice is generally to try and ignore verbal insults if you can. Don't take it personally. But you have to set clear limits on any physical aggression for everyone's safety. The chapter references a table with strategies for specific difficult behaviors like anger or suspiciousness.
Okay. Thinking about the overall nursing process, you said risk for injury is the top diagnosis.
It really is the priority, but many others are relevant. Impaired physiological status, issues with temperature, fluids, breathing, nutrition, sleep, toileting, cognitive ones like acute confusion, impaired memory, perceptual ones like hallucinations, communication difficulties, self-care deficits, mood problems, fear, anxiety. The list goes on.
And the overarching goal?
Always to return the patient to their baseline, their level of functioning, before the delirium started.
So specific outcomes might be things like remaining free from falls while confused.
Yeah.
Increased orientation.
Exactly. Staying safe, free from injury. And it's crucial to remember that safety is the staff's responsibility, even if family is there. Sometimes one-to-one sitters are needed in hospital.
And evaluation involves looking at short-term stability and long-term recovery.
Yes. Short term. Are they physiologically stable? Are they safe right now? Long term. Are they still safe? Are they oriented by discharge? Is the underlying cause treated? Have they returned to their pre-morbid functional level?
The chapter has that story about Mr. Arnold. It really drives home what happens when delirium isn't managed well.
It's a powerful example, unfortunately, of failures in assessment, recognizing risks, communication, safety, a real cautionary tale.
It highlights the need for better awareness and protocols.
Absolutely. And the chapter points listeners towards resources from the ANA and American Delirium Society for more on best practices.
Okay, so that's delirium. Let's maybe shift gears now and talk about Alzheimer's disease as a major example of a neurocognitive disorder.
Right. But maybe first, can we quickly clarify the difference between major and mild neurocognitive disorders? You mentioned the DSM-5 before. What is that exactly for our listeners?
Good point. The DSM-5 is the Diagnostic and Statistical Manual of Mental Disorders, 5th edition. It's basically the standard classification used by mental health professionals.
Okay. So for neurocognitive disorders, it sets out criteria for both mild and major forms. Both involve a decline from a person's previous level of functioning in one or more cognitive areas: attention, executive function, memory, language, etc.
But the difference is the severity.
Exactly. In mild NCD, the cognitive decline is noticeable, it's modest, but it doesn't interfere with their independence in daily activities. They might need to use compensatory strategies or put in more effort, but they can still manage.
Okay, makes sense. And major NCD?
That's where the cognitive impairment is substantial, and it does interfere with their independence in everyday life, those activities of daily living, or ADLs we sometimes talk about.
Right, things like bathing, dressing, managing finances.
Precisely. And there's also something called mild cognitive impairment, or MCI. It's not a formal DSM-5 diagnosis itself, but it's seen as this intermediate stage.
Between normal aging and dementia.
Sort of. People with MCI have difficulties with memory, language, thinking, judgment that are beyond typical aging, but not severe enough to be dementia. But importantly, having MCI does increase the risk of eventually developing dementia.
So any noticeable cognitive decline warrants a proper checkup.
Absolutely. A thorough assessment, including those formal mental status exams and a full medical workup, is crucial for an accurate picture.
Okay, so let's zoom in on major neurocognitive disorder, which is often just called dementia in everyday language.
Right. Dementia is that general term for a severe decline in mental ability that really impacts daily life. Major NCD, as defined by DSM-5, usually develops slowly, gradually, unlike the rapid onset of delirium.
And it affects multiple cognitive areas.
Yes, multiple areas progressively get worse. Complex attention, executive function, that's things like planning, decision-making, abstract thinking, learning, and memory, language, perceptual motor skills, social cognition. It's a broad decline.
And these major NCDs or dementias can be primary or secondary.
That's right. Primary ones like Alzheimer's, vascular dementia, Lewy body disease are generally considered irreversible. The disease process is directly affecting the brain.
And secondary.
Secondary dementias are caused by other conditions like thyroid problems, vitamin deficiencies, even some infections. If you treat that underlying cause, the cognitive symptoms can often improve or even resolve. But most dementias are primary.
And Alzheimer's is the most common of those.
by far. It accounts for, well, estimates vary, but somewhere between 60 and 90% of all dementia cases.
Wow. It's huge.
It really is a major cause of disability and death, and the prevalence just keeps rising as the population ages. And it is primary, progressive, and currently irreversible.
What drives that risk? What makes someone more likely to develop AD?
Age is the single biggest risk factor, no question. The risk roughly doubles every 5 years after age 65.
And gender plays a role?
Seems so. Almost 2/3 of Americans with Alzheimer's are women. Family history is also significant. Having a first-degree relative, like a parent or sibling, with AD increases your risk.
Are there lifestyle factors, things we might have some control over?
Yes, and this is really important. There's good evidence linking cardiovascular health to brain health. So things that are bad for your heart are often bad for your brain.
Like smoking, obesity, high blood pressure.
Exactly. Lack of regular physical activity, poor management of those cardiovascular risks, including impaired glucose processing or diabetes, all linked to higher risk. Conversely, staying active, managing blood pressure, maintaining a healthy weight, those seem protective. Clinical depression has been associated with increased risk, lower levels of formal education, lower socioeconomic status too. And there's ongoing research suggesting lifelong social and mental activity might be protective.
So keeping your brain active and engaged.
Seems to help, yes. On the flip side, sensory deprivation, social isolation, and moderate to severe traumatic brain injuries have also been suggested as potential risk factors.
The chapter mentioned findings from the Framingham Heart Study.
Yeah, interesting findings there, pointing to things like being widowed, having a lower BMI, and getting less sleep in midlife, potentially being associated with higher dementia risk later on. Lots of factors seem to interact.
And genetics. The APOE gene often comes up.
Yes, genetics definitely play a role. The APOE E4 variant is a major genetic risk factor. Having one copy increases risk, 2 copies increases it substantially more, but it's not a guarantee you'll get AD.
It just increases the odds.
Right. There are also very rare mutations in genes like ABP, PS1, and PS2 that cause early onset familial AD. These are much more deterministic, but account for only a small fraction of cases. And people with Down syndrome have a much higher risk because the gene for amyloid precursor protein is on chromosome 21.
It's complex, and the chapter also brings up cultural aspects.
Yes, and that's crucial. While the biology is similar, incidence rates differ across ethnic and racial groups. African Americans and Hispanic Americans seem to have higher rates than white Americans, while Asian Americans generally have lower rates.
Why is that?
It's likely complex, potentially linked to differences in cardiovascular risk factors, access to care, socioeconomic factors. It's an area needing more research. But culture also shapes the experience.
How so?
Beliefs about aging, whether memory loss is seen as normal or a disease, stigma, these can all affect recognition, seeking help, the kind of support families receive, language barriers, economic factors. They all play a part. A culturally sensitive approach is vital.
Okay, let's get into the biology. What's actually going wrong in the brain with AD?
The chapter highlights several key pathological hallmarks. The big ones are amyloid plaques. These are abnormal clumps of beta amyloid protein that build up between nerve cells.
Like roadblocks.
Kind of, yeah. They disrupt communication. Then there are neurofibrillary tangles. These are twisted strands of a protein called tau that build up inside nerve cells.
And they mess up the cell's internal transport system.
Exactly, leading to cell dysfunction and death. You also see synaptic deterioration. The connections between neurons break down and widespread neuronal loss.
The chapter mentions a few hypotheses about how this starts. The amyloid cascade.
Right. That's been a dominant theory for a long time. It basically proposes that abnormal processing of the amyloid precursor protein, APP, leads to an overproduction of sticky beta amyloid fragments. These fragments clump into plaques, which are thought to trigger a cascade of events, including inflammation and tangle formation, ultimately killing neurons.
And the cholinergic hypothesis.
That focuses on the loss of cells that produce acetylcholine, a key neurotransmitter for memory and learning. Beta amyloid seems to interfere with the acetylcholine function too. Many current AD drugs target this system.
What about the tau protein hypothesis?
This suggests that abnormalities in the tau protein itself are a primary driver. When tau becomes hyperphosphorylated, chemically altered, it clumps into those tangles inside cells, disrupting their function and leading to cell death, independent of or alongside the amyloid pathway.
So it might not just be amyloid.
Increasingly, the thinking is that it's a complex interaction. Neuroinflammation, the brain's immune response going awry, is also heavily implicated. Oxidative stress and imbalance favoring cell-damaging molecules plays a role. Problems with calcium regulation within cells, too.
It's a multi-pronged attack on the brain cells.
Pretty much. And all this cellular damage leads to visible changes in the brain structure.
Like shrinkage.
Yes, significant cortical atrophy, especially in areas vital for thinking, planning, memory, language. The hippocampus, which is crucial for forming new memories, is usually hit particularly hard and early. And the ventricles, those fluid-filled spaces, often enlarge as brain tissue is lost.
The disease progresses through stages. Can you walk us through those? Roughly what happens when?
Sure. The chapter describes 4 overlapping stages. Stage 1 is mild AD, often characterized by forgetfulness. Short-term memory is usually the first casualty, losing things, difficulty learning new information.
But they can often compensate with notes and reminders.
Yeah, memory aids help at this stage. Crucially, the person is often aware there's a problem, which can lead to anxiety or depression. Symptoms might not be specific enough yet for a firm diagnosis. Mr. Collins in the vignette, forgetting wires, names, conversations, that's typical.
Okay, what's next? Stage 2.
Stage 2 is moderate AD. Here, confusion becomes more pronounced. Memory loss gets worse and clearly interferes with daily life, managing money, driving, cooking, sometimes getting lost.
Social withdrawal might start.
Often, yes. Denial is also common at this stage, maybe trying to cover up the deficits. Fear of losing one's mind can worsen depression. Confabulation, making things up to fill memory gaps, might appear. Stress makes everything worse. This is often when daycare or home help becomes necessary.
Mr. Collins getting lost, needing early retirement.
Exactly. The angry outbursts, restlessness, wandering, that all fits stage 2.
And then stage 3, moderate to severe.
Right. Stage 3, moderate to severe AD, sometimes called ambulatory dementia because they can still walk. But now, deficits in activities of daily living are significant. Bathing, grooming, dressing, toileting, eating, communicating, all become difficult.
Reasoning and judgment are severely impaired.
Very much so. Safety becomes a major concern. Language abilities decline further. Frustration is common, but depression might actually lessen as their awareness of their own decline diminishes. They have a much lower stress threshold. Institutional care often becomes necessary.
The vignette describes Mr. Collins as terrified, not recognizing people, hiding things.
Yes, profound confusion, misidentifying people and objects, wandering, hallmarks of this stage.
And the final stage. Stage 4.
Stage 4 is late stage or end stage AD. Here, the person may lose the ability to recognize even close family. They often become non-ambulatory, may lose the ability to speak, or might just make sounds or scream.
Eating and swallowing become problems.
Major problems. Forgetting how to eat, swallow, chew leads to weight loss, malnutrition. Immobility brings risks like pneumonia, pressure ulcers, contractures. Incontinence is common. Seizures can occur. Full-time institutional care is almost always required.
Primitive reflexes can return?
Yes, things like the grasp reflex. You might see hyperorality, putting everything in the mouth, or hypermetamorphosis, needing to touch everything. Emotions become blunted. They lose the ability to recognize objects or people. Agnosia. It's a devastating stage.
A truly difficult progression. How was a formal diagnosis actually made, according to DSM-5?
Well, the criteria for major or mild NCD due to AD require evidence of cognitive decline from a previous level based on concern from the individual or an informant and objective testing. The onset has to be insidious, gradual, and the progression slow.
Memory and learning impairment must be present.
Yes, particularly memory and learning decline, plus decline in at least one other cognitive domain for major NCD. And crucially, the decline needs to be steadily progressive, without extended plateaus, and not better explained by another condition.
So differentiating it from delirium or depression or other things is key. How do clinicians do that?
That differential diagnosis is critical. As we discussed with delirium, onset, fluctuation, level of consciousness are key differences. Depression can cause pseudo-dementia symptoms, but usually cognition is more intact on testing, and treating the depression helps.
So a full workup is needed.
Absolutely. Complete medical history, physical, neurological exam, psychiatric assessment, medication review, nutritional status check. All essential. Rule out those other potential causes, drug toxicity, metabolic issues, infections, deficiencies.
Is there a definitive test for AD itself, like a blood test or brain scan?
Not yet. Not a single definitive one for routine clinical use during life. Brain scans like PET can show amyloid plaques, and CSF analysis can measure amyloid and tau, but they're often used more in research or complex cases. There's exciting research on blood tests, but they're not standard yet.
So imaging like MRI or CT is mostly for ruling other things out.
Primarily, yes, ruling out strokes, tumors, hydrocephalus, etc. Diagnosis still relies heavily on the clinical picture, history, and cognitive testing.
What kind of cognitive tests?
Brief screening tools like the Mini Mental State Exam, MMSE, the Montreal Cognitive Assessment, MoCA, SL, IHEFAS, or the Mini-Cog are common starting points. The Mini-Cog, for example, is very quick. Remember 3 words, draw a clock, recall the words.
These are just screeners, though.
Right. They indicate if more detailed testing is needed. Neuropsychological testing provides a much more comprehensive assessment of different cognitive domains and is often key for a more definitive diagnosis or tracking changes over time.
The chapter talks about defense mechanisms and the 4A's. What are those?
As cognition declines, people might unconsciously use defenses. Denial is common, sometimes hidden behind good social skills. Confabulation, filling memory gaps with plausible but untrue stories, isn't lying. It's an attempt to maintain self-esteem.
Perseveration.
Repeating words, phrases, or actions, often worse under stress. And avoiding questions to hide deficits. Then the 4A's summarize key cognitive losses. Amnesia, memory loss, starting with recent, then older memories.
Aphasia.
Language problems, difficulty finding words, eventually maybe becoming mute. Apraxia, losing the ability to perform purposeful movements, like coordinating steps to walk or using utensils. Loss of ability to recognize things through the senses, not recognizing familiar sounds, objects by touch, eventually even faces, including their own reflection. Plus, major problems with executive functioning planning, organizing, abstract thought.
That gives a clearer picture of the deficit. So, when assessing someone, what are the key guidelines clinicians follow?
It's really comprehensive. Identify and treat any contributing medical issues first. Assess safety risks, suicide, harm to self or others. Review all medications. Evaluate their current cognitive function level.
And involve the family.
Absolutely. Assess the family's understanding, preparedness, coping mechanisms. Check for potential neglect or abuse, sadly. Review their support system, family, friends, community services. Determine safety needs, especially at home, wandering risks, falls, handling medications, and figure out what education the family needs.
Based on that assessment, what kind of nursing diagnoses come up frequently?
Risk for injury is huge, obviously. Impaired communication, memory, cognition, chronic confusion, disorientation, self-care deficits, bathing, dressing, eating, nutrition problems, mobility issues, and crucially, caregiver stress or role strain. Dysfunctional grief for the family, too. The chapter has a detailed table.
And the goals, the outcomes you'd aim for.
Focused on safety, communication, managing the environment, self-care, and caregiver support. Things like the person remains safe, uses communication strategies, recognizes familiar things, participates in self-care as able, and for the caregiver, expressing feelings, using resources, getting respite. Box 18.2 lists many examples.
And the chapter emphasizes caregiver support as central to planning.
Absolutely central. You have to focus on the patient's immediate needs, ADLs, orientation, mood, activities, but understanding the caregiver's situation is just as critical. Identifying the level of dementia, maybe using a scale like the Blessed Dementia Scale, helps tailor support.
Connecting families with resources.
Essential. Table 18.9 lists support services. Proactively addressing caregiver stress, providing education. It's key.
What helps caregivers most?
Realistic expectations about the disease and outcomes, recognizing small wins, and prioritizing their own self-care, sleep, nutrition, exercise, relaxation, social connections. It's a marathon, not a sprint.
The attitude of the care team matters too.
Unconditional positive regard, validation of feelings, both the patients and the families. Acknowledging the family's exhaustion and sense of loss is vital. Teaching them about the illness progression and safe care is ongoing.
Communication becomes so hard. What strategies help?
Well, recognizing the challenges, word finding, repetition, losing thoughts. Validation therapy can be powerful. Focus on the emotion behind what they're saying, not just the literal facts. Like the wedding ring example, validate the feeling of loss. Don't just argue about where the ring is.
Reality orientation.
Gentle reality orientation, using their name, stating the day can help, but avoid forcing unpleasant truths they've forgotten. Reminiscence therapy, talking about the past, can be comforting and boost mood.
Table 18.7 has specific tips.
Yes, really practical stuff. Identify yourself. Speak slowly, simply, face-to-face, one thing at a time. Use familiar topics, encourage reminiscing. Acknowledge delusions, but gently reinforce reality, don't argue. Shift the topic if they get aggressive. Ensure sensory aids are working. Use environmental cues, clocks, calendars, photos.
Like in the Mr. Sampson example, using the memory book.
Exactly. Applying those principles compassionately.
And teaching families is crucial. What do they need to know?
Table 18.8 covers it well. Disease progression, communication techniques, managing difficult behaviors like agitation. Figure 18.3 suggests sensory, active, psychological approaches, planning activities, types of care available, daycare, home care, respite, hospice, community resources, future planning, legal, financial, caregiver stress management, and creating a safe home environment. Table 18.9 has specifics on dressing, eating, wandering activities.
The Alzheimer's Association is a key resource there.
Invaluable. Website, helpline, safe return program, fantastic support.
The chapter also mentioned milieu therapy and an EBP example about wandering.
Yeah, a great example of person-centered care. Instead of just alarms for an older man who wandered, they learned about his past on a farm, his love of nature, and incorporated walks and nature activities. It worked much better and addressed alarm fatigue too. Safety, patient-centered care. Really good illustration.
Okay, finally, treatments. Pharmacological options. Is there a cure?
Sadly, no cure yet. There are cholinesterase inhibitors, donepezil, rivastigmine, galantamine that boost acetylcholine levels. They can provide modest temporary help with cognition and function in mild to moderate AD.
Slowing progression for a bit.
For maybe 3-6 months for some people. Common side effects are GI issues. There's also memantine for moderate to severe stages, which works on the glutamate system. Lots of research ongoing, over 100 drugs and trials, experimental things like deep brain stimulation, but no breakthrough cure yet.
What about managing the behavioral symptoms, BPSD?
That's a huge challenge. Non-drug approaches are first line. Music therapy often helps with agitation, behavioral management, staff training, caregiver education, tailored activities, TAP, sensory approaches like massage. These can all make a difference.
A DICE approach.
Describe, investigate, create, evaluate. A structured way to understand and manage behaviors, looking for triggers, pain, UTI, constipation, unmet needs, boredom, fear, medication side effects.
So, addressing the underlying cause of the behavior.
Exactly. Creating a safe home environment. Table 18.2 has tips on restricting driving, removing hazards, safety locks, labeling things, managing wandering with alerts or GPS. Useful, simple activities are important too.
And medications for behavior. Use cautiously.
Very cautiously. Risk of falls, sedation, worsening cognition. Antipsychotics have that black box warning about increased mortality and dementia. Patients use low dose, short term, if absolutely necessary. Antidepressants, SSRIs preferred, can help if there's depression or sometimes agitation. Benzodiazepines are generally avoided due to risks. Always weigh risks and benefits carefully, especially in older adults.
The chapter also recaps the neurobiology, acetylcholine, glutamate, plaques, tangles, atrophy.
Yes, tying it back to how the approved drugs work, like cholinesterase inhibitors boosting acetylcholine and memantine modulating glutamate. And it mentions the finger study.
Lifestyle interventions.
Right, showing that combining physical activity, healthy diet, managing vascular risks, and cognitive training can actually benefit cognitive function in at-risk older adults. Very hopeful results.
So ongoing evaluation is key throughout this journey.
Absolutely. Goals need to be realistic, measurable, adjusted as the disease progresses. Frequent reevaluation prevents frustration. The aim is always to maximize function, slow decline, and support quality of life for both the person and their family through collaboration and resources.
Okay, so let's just quickly recap the main takeaways. We've got neurocognitive disorders.
Right, delirium, major mild NCD, dementia, and that intermediate stage, MCI.
Delirium. Acute onset, fluctuating course, always secondary, potentially reversible.
Yep, MCI, cognitive decline, but independence maintained, higher dementia risk.
Major mild NCD, dementia. More gradual onset, progressive decline, impacts independence, especially major NCD. Often irreversible, like Alzheimer's.
AD being the most common type, linked to age, genetics, lifestyle factors, progresses through stages with characteristic cognitive losses, the 4As.
No cure. But some drugs offer limited symptomatic help, and non-drug approaches are key for managing behavior and supporting function.
And the stark difference really stands out, doesn't it? Delirium, the acute, often treatable confusion, Alzheimer's, that long progressive decline. Understanding that distinction is fundamental.
Absolutely. And it's just so clear how profoundly these conditions affect individuals and their families. It really demands enormous empathy, patience, understanding.
It really does. From everyone involved.
So as we wrap up this deep dive, maybe a final thought for you, our listeners, to ponder. With neurocognitive disorders becoming more prevalent as populations age, what do you think are the most critical steps we need to take as individuals, as communities, as a society, to really improve the support systems for people living with these conditions and for the incredibly dedicated caregivers who support them?
That's a huge question, isn't it? Thinking about creating dementia-friendly communities, ensuring access to resources, funding research. It's multifaceted. And if you do want to learn more or find support, resources like the Alzheimer's Association or the American Delirium Society websites are excellent places to start.